Yeah.
Excellent.
Yeah.
So first of all, thank you very much. I'm Vinayak Bapat. I'm Chief of Cardiac Surgery at the Abbott Northwestern Hospital and United in Minneapolis. And my current topic is transcatheter mitral valve replacement, current status, and the future. So these are my disclosures. So this is the landscape. I'm just taking you back 10 years now. This is how it was started, and there was a lot of hope that TMVR is going to emerge similar to TAVR and much faster. However, if you can see that the first case was done in 2012, we did a case just few weeks later, actually in London, with Edwards device, and now, of course, this landscape has changed completely, and there are a lot of other new devices, mainly transeptal, which are probably leading the race. So if we look at the classification, as most of the transcatheter devices, transapical used to be the main access route. You can see Tendyne, Intrepid, Tiara, Fortis, Saturn, and 4C. All these devices started as transapical, but there has been a shift now towards transeptal approach because it's less invasive. There are a couple of devices still in combination, that is transapical and transeptal, but the latest generation of high life is now completely transfemoral. The more important, I would say that classification could be based on anchoring. As you know, the mitral valve is much bigger, more dynamic with varied pathology. Most of the devices leverage anchoring based on leaflet and annulus. So if you look at Tendyne and Cephia as a device, they anchor mainly at the annulus based on oversizing. But there are devices like Intrepid, Cardiac Q. These tend to have a combination, that is leaflet and also the oversizing at the annular level. There are some devices which I'm going to show you later which have a very unique mechanism. So why is TMVR complicated? As you know that mitral valve, you can't see it under fluoro either. And hence there are a lot of these new designs like a dual frame design of Intrepid. You can see that it's a big outer conformable frame, but the inner valve, which is 27 millimeter pericardial valve, remains circular and intact. And the CT scan on the right side is one of my first patients done in 2014. You can see that the outer frame is deformed because of the D shape, but the inner wall is circular. As I said, initially the delivery system was all transapical, and there's a very large experience with this. We have recently published experience with 5-year and 2-year follow-up echoes on these patients of more than 300 patients now. And you can see that the advantage of these devices, because they were bigger, was easier to deliver directly into the mitral valve. However, this is more invasive as the delivery system is as big as my thumb, and you're making a big puncture in a very sick ventricle. So now we are doing this case as transeptal. This is one of the early cases of same device, Intrepid, and you can see that you can have a better visualization actually if you go through transeptal, and the anchoring remains the same. The largest experience in TMVR, however, comes with Tendyne device, which was Abbott. Now it's been withdrawn from market. It will be probably only indicated for severe MAC patients. But this device was only transapical, and that's the main reason I think they have decided to withdraw it. But this is again one of my cases from Abbott Northwestern, a patient who is very sick, and you can see extreme calcification of the mitral. This patient had a transapical tendine device. This is a CT scan done 3 months later. Now, there are newer systems, and these newer systems are very unique. As you know, that imaging science has got better. So intra-op transesophageal echo, you can do now MPR views, you can do 3D reconstructions. Now the concept of valve in a ring has emerged as one of the easiest ways to do TMVR. So this is the Edwards Sapien M3 system. You can see how it is done is you put a dock which is subvalvar. So you just go around all the cords, pull it up under the subannular structure or level, and then deploy a fully covered Sapien 29-like device. This is one of the cases from Vancouver done by John Webb. and you can see that very beautiful result at the end of this. One of the main issues here has been if it's a very large annulus, you can only reduce it to a point and then you can get paravalve leakage. So the second generation dock has got some unique solution in terms of reducing that paravalve leakage. This is a completely out of box design. I know most of us surgeons will chuckle at this. This is called a Alta valve. This valve essentially is a very soft nitinol cage which sits in the atrium, and the valve juts into the ventricle only by 1 centimeter. The biggest advantage of this device is that it doesn't go into the LV, so it doesn't deflect the anterior mitral leaflet into LVOT, causing LVOT issues. This is one of the early cases, so it's a chimney-like valve which sits more in the atrium. Strange enough, they have done now more than 60 cases, and we just did 2 cases last Monday. They have gone spectacularly well with a procedure which is less than 45 minutes. High Life, as I said, is another device which came in with this ring and a valve concept. Again, just to highlight that these concepts are now looked into as more favorable as the delivery system is divided into two. One is the dock and one is the valve, and hence the size of the delivery system is literally like a pencil on the table. Cephia is the last and the new incomer. This is by Abbott Laboratories. This device is like an Amplus plug. That's the concept at least. And the beauty of that device is it's a very short profile. Evoke is a Edwards device. This has been now approved to use in tricuspid. We have heard recently that generation 3 might make a comeback in the mitral as well. So multiple devices. So why there are less than 2,000 cases done in the world in last 10 years? And these are the challenges we faced when we are enrolling TMVR. Let's not forget that surgical valves which we implant today have been developed for 60 years. A TAVR which we implant today every day has been took nearly 20 years or 22 years to develop. So I think it is still early in case of TMVR, and I am very confident that in next few years this will become a mainstream therapy as well. But one of the main challenges is LVOT. And as I said before, this is like a fixed SAM when you implant these devices. And this has been the main Achilles heel because when we screen patients, the failure rate of screening is nearly 70 to 80%. So there are multiple solutions. You can make a valve which is D-shaped. However, this is very hard to orient and deploy when you go transeptal. Now, there are these newer concepts, as I said, Cephia and Altavalve, which appear slightly, out of box, but at the same time have less issues because less amount of device sits in the LV. And this is just one of the cases you can see that this with this Altavalve, actually in systole, the LVOT increases because the outer frame compresses down. We don't know the long-term effects in terms of stent fracture in this situation, but that will, of course, time will tell us. Other solutions such as gathering the leaflet, as I said before, these concepts may be useful in some of the cases. And lastly, but not the least, is very innovative electrosurgery, as they call it, is a splitting of the anterior leaflet, making the valve design such that the outer cells are wide open, such as in High Life. And there are new solutions such as a sesame solution where myectomy or a myotomy is done, or the alcohol septal ablation, which can be done to increase the LVOT. Lastly, but not the least, mitral annular calcification can be challenging, especially in old women with small ventricles. As we know, these patients have diastolic dysfunction as well. So doing surgery in this, a lot of surgeons don't want to do it. And in these cases, TMVR has been really promising. And these are 4 different devices with excellent results now in MAC. And I see that these patients are actually going to be one of the main candidates for TMVR in future. So in conclusion, the TMVR progress appears to be slow, but in my opinion, it's not slow. Transeptal approach is the approach now. There's not going to be a single transeptal device. And I think newer designs are addressing newer problems. And I still feel very strongly that in next 2 to 5 years, we are going to see TMVR embedded in our practice. Thank you.